I'd like to thank Carlo Palmieri and the summit organisers for the opportunity to present on the National Audit of Metastatic Breast Cancer on behalf of the project team, whose names are listed on this first slide. NAOMI, as it's known, is one of a number of national cancer audits that are commissioned by the Healthcare Quality Improvement Partnership, otherwise known as HQIP. There's an audit of primary breast cancer, which we're all part of as well, and a number of other cancer types. And the common aims of the audit are to provide information on the performance of NHS organisations with the aim of driving quality improvement by highlighting inequalities of care and flagging those organisations where we've set a performance indicator where the care falls short of that indicator. The audits are required to use existing national cancer data sets in England and Wales. This is data that's collected routinely on patients as they pass through NHS organisations, and it includes information on diagnoses, treatments and outcomes. We've established strong links with professional and patient groups, primarily through our Audits Advisory Committee, which meets twice a year and includes representation from both public and professional organisations. One of the first activities of the audit was to conduct a scoping survey in the early part of 2023. We asked stakeholders, including patients and professionals, to identify common themes where they felt care may be lacking and we needed more information to help drive treatment forward. There was a remarkable level of consistency between the items that were highlighted. One of them was data completeness and our ability to capture patients with metastatic disease, but also patient subgroups including triple-negative breast cancer, younger patients with cancer, older patients and male patients. Although common themes included staffing and resource, in particular specialist metastatic breast cancer nursing, and also oncology and radiology provision, because these are services that are provided, not things that are happening to patients, they're not included in the routine data sets, and HQIP specifically prevent the audits from conducting the kind of organisational surveys that would be required to collect this information. So what data is available to us? Well, we have data on national cancer registrations. There's an extensive cancer outcomes and services data set. We can see hospital episodes, so inpatient, outpatient and day case episodes, systemic anti-cancer therapy use, radiotherapy, obviously mortality data, primary care prescriptions, specialist genetic testing, cancer waiting times data, diagnostic imaging, and the National Cancer Patient Experience Survey. So that's in England. And in Wales, it's a little bit simpler with just cancer records, episode statistics, radiotherapy, and mortality data. And the first look we get at the data comes from the Rapid Cancer Registration Dataset, which provides a quick indicative source of cancer data compared to the gold standard registration process. And I'll show you the differences in just a minute. So this is focused primarily on the incident cases of cancer, so new cancers diagnosed. And it's not as good as we hoped at picking up people who start with a primary cancer diagnosis, so would be included in the primary audit, and then subsequently develop recurrence and would shift over into the metastatic audit. So what are the differences between rapid cancer registration data and gold standard? Well, they're summarised here. Most of the rapid data comes from death certificates, cancer waiting times data, hospital episode statistics, so when things happen to patients, and they're part of the cancer outcome and services data set. They're available around 4 months post-diagnosis according to their website. The first data were from January 2018, which is an important date for the audits, and they include data on 13 cancer types, including breast cancer. And then over time, a rather more complete gold standard National Cancer Registration Set is collated, which includes the other feeds listed here, and it takes up to 2 years post-diagnosis for the full reporting of all clinical details, and is available over a longer timescale from January 1995 in what's known as ICD-10. That's the International Cancer Classification of Diseases. And it stages all stageable cancers. And the expectation is that rapid cancer data will ascertain 98% of new cases, but will only have staging on 63%, whereas the gold standard will have 86% staging completeness and hopefully complete capture. But that focuses very much on stage at presentation. So all of these multiple feeds are then worked up into a data file that's released to the individual audits. As I've said, the rapid data is the main file, and then we get these additional data feeds. So there are multiple data lines per patient included in the audits. And it's the job of our data scientists on the team to format the data and, most importantly, take those multiple feeds for individual patients and come up with a single patient row that includes patient and tumour characteristics, treatment details and outcome details. And once that data has been processed, we can start then to look at our audit questions, describe the care indicators, treatments given and survival, and come up with the data that we hope will be driving improvements in care. So one of the first questions we grappled with was how many patients should be included or would we expect to be included in the metastatic audit. And there are very few data on the incidence of new cases of metastatic breast cancer, although there are ways that have been used to estimate. So first on this list is Carlo Palmieri's attempt back in 2022. That was using hospital episode statistics data, and he worked out that the prevalence of breast cancer was roughly 57,215 cases. So that's people living with a metastatic diagnosis in those years. And I personally think that's a pretty good estimate. Breast Cancer Now, back in 2019, came up with a number of 35,000. My sense is that that's probably an underestimate. Macmillan in 2021 came up with 12,209 treatable but not curable. Again, I think that's an underestimate. And an Australian study came up with the idea that if people on average with breast cancer at the time they looked at this in 2012 were living for 3 or 4 years, then the number of patients with a breast cancer diagnosis, metastatic breast cancer diagnosis at any given time would be 3 to 4 times the death rate, so between 34 and 46,000 cases. And I think that's important for one reason, because we would expect the incident number of cases in any given year to be reflected in the number of deaths a few years later. And so the incident number is probably going to map roughly onto the number of deaths and is going to be in the region of 10 or 11,000 cases a year. So how do we identify these patients? Well, they are identified either with stage 0 to 3, so in situ to stage 3 cancer, and they would be put into the primary audit. But if their ICD code, so their disease classification code, is breast cancer, and they're recorded as stage 4 or having metastatic disease, they then go into the metastatic breast cancer audit, and that initially identified population is the what we call the de novo. So those people are presenting who already have metastatic disease. Where it gets more complicated is patients who start with a primary breast cancer diagnosis, complete treatment, that you can argue about how long that window of opportunity for primary treatment should be, and then go on either directly to have a distant recurrence or have a local recurrence and then a metastatic recurrence. And that transition is not consistently recorded in routinely available data. And there's no validated way to flag patients with distant recurrence in routine national data sets, so we're reliant on algorithms, and some of you may be aware of a recent publication from the Oxford group looking at an algorithm that looks to perform pretty well in identifying these patients. But even if we can identify them, identifying the date of recurrence remains a challenge. So what data do we have? Well, our initial Rapid Cancer Registration Database return started when it started in 2018 and collected data up to the 30th of June 2023, so at roughly 5.5 years. There were 277 new cases of invasive breast cancer in England and Wales, so it excludes the numbers in Scotland and Northern Ireland. And of those, 92% were in Naopri and just under 8% in Naomi, and that's about the split you would expect. When you then move into the people who started in Naopri and have moved into Naomi recurrent, there were only 6,000. That represents 2.5% of Naopri, and our sense is that that number is rather lower than we would expect. If you turn that round the other way, in Naomi there were 28,000 cases. That's including the recurrent and the initial diagnosis. And we think there's an unrecorded number and have been working very hard on trying to get a number that reflects the actual number of people who present with primary curable breast cancer but then move on to have a metastatic diagnosis. What about the data that we've got? Well, the first observation, as you can see here, is there is a preponderance of patients over the age of 70, and we think that represents women over the age of 70 who are presenting with metastatic disease as their first sign of breast cancer, and the younger age groups are proportionally underrepresented. What information do we have on them? ER status we have in 46%, but it's missing in that rapid cancer data set in about 40%. HER2, 14% HER2 positive. That is with a definite diagnosis of HER2 positive, 46% HER2 negative. And again, there's a large number of missing cases, 29%. And those are rather longer term data from 2015 to 2021. And then we have some outcome data on the initial metastatic, so patients who present with metastatic disease, showing that their survival was just over 2 years, and survival declines with increasing age. So the much older patients over the age of 70 who present and already have metastatic breast cancer sadly have really quite a poor outcome. So what are our data outputs? Well, we published a healthcare improvement plan in 2024, and we are required on an annual basis to publish a State of the Nation report. The first one was published in September 2024, and we publish quarterly dashboards online, and I'll just signpost those. So in our first State of the Nation report back in 2024, we summarised the findings for the patients and public. And we looked at 17,055 patients diagnosed between 2019 and 2021 in England and Wales, of whom 99% were women. We've already seen the de novo versus recurrent split. We then looked at data completeness, so tumour grade, tumour stage, hormone receptor status, HER2 status, and there's this recurring theme about the number of people with recurrent metastatic cancer being lower than we expected. We've reported on the number of patients where it is recorded that they've been discussed in a multidisciplinary team meeting. Clearly, if the discussion takes place and it's not recorded, we don't capture it. And the number of people who've had a biopsy, which is about 34%. And then clinical nurse specialist contact, there was a high level in both England and Wales. And we're starting now to look at the number of people who get the various different treatments that are available. So 4 in 10 people with de novo ER positive HER2 negative breast cancer received CDK4/6 inhibitors. Some of those will have received chemotherapy. Some of them will have gone on to primary endocrine monotherapy. And around 8 in 10 people received anti-HER2 treatment. Finally, these are the dashboards. This is the website, and it allows you to look at either Cancer Alliance or at individual hospital trusts with respect to various different reporting functions. And I say, in the interest of time, I can't speak about that. And then finally, and one of our ways of improving data completeness is we've produced a guide in collaboration with the Cancer Outcomes team, looking at ways of coding metastatic disease to help clinicians to record it. So at that point, I'd like to thank you, and I'd be very happy to take any questions that you may have.
Great presentation, and thanks for all your hard work. I know you've been a strong advocate and have faced challenges in delivering this project. So thank you very much for the presentation and dialing in. So are there any questions for Mark? Lady over there. So Mark, while the mic's just going, where next? What do we do next? What do we do with this data? How do we plug the gaps?
I think that the way we identify people with metastatic disease is really important. And the fundamental problem is that the National Disease Registration Service focuses on new cancer diagnoses. And so if somebody presents with a new cancer, that is very accurately captured. But if they've had a primary cancer and then developed metastatic disease, the capture of that is much less reliable. And the problem is that we can't interrogate hospital data systems. We have the information that's given to us that's captured during routine treatment. And the most accurate information comes from people who get admitted to hospital. And as everybody in the audience will know, particularly at the first time of diagnosis, a lot of those people aren't being admitted to hospital, they're being managed as outpatients. So I think the Oxford algorithm will help us in a sense, but the problem is that the Oxford algorithm can be applied to National Disease Registration Service data, but we can't apply it. We have to get them to do it if we want to use it. And we've also found some more creative ways of identifying patients to do with coding. It's incredibly complicated, but one of our team members has come up with a solution that seems to be increasing the number of people that we're capturing with metastatic disease by up to 50% actually. But ultimately, it's what goes into hospital data systems during routine treatment that we can see. We can't question it. All we can do is interpret the data that we're given.
Lady has got a question.
Quite a naive question, but why is it so important to have these data? Does it affect treatment? Does it affect funding? What?
Did you hear that, Mark? So the question is, why is it important we collect the data if people didn't hear that question?
The first reason is that if you think about most clinical trials in cancer, especially in metastatic cancer, they include a few hundred people. And we may be applying that data to thousands of women in England and Wales because Scotland and Northern Ireland have chosen not to take part in the audits. So it's useful to show in the real world that treatments perform the way that they do in clinical studies. So that's reason number one. The second reason, which is probably more important, is that we can track on a Cancer Alliance and trust level what treatment is being given. And for instance, in the presentation, we showed you that 40% of people overall are receiving CDK4/6 inhibitors for hormone receptor positive disease. But we can look at outliers. So we can look at trusts where up to 60% of people who are given the treatment, and we can look at trusts where it seems that less than 10% of people are being given the treatment. And if we highlight those extreme variances, we can then encourage institutions to look at their own data and try and understand why they're outlying. And we hope that that will overall drive improvements in care.
So I'm going to bring Anne in. So Anne's from Northern Ireland. I need to pay tribute to Anne. So Anne's an example of where a patient advocate gets involved in a project, becomes the stone in the shoe of the organisation. Because I think having stones in shoes is really important, because as we all know, if you have a stone in your shoe, you want to get it out. So Anne was a stone in the shoe in Northern Ireland, helped drive forward the data collection. So Anne, over to you, your observations, the learnings from Northern Ireland.
Yeah, so thanks very much, Carlo. So Mark, it was just to say, I have seen the Oxford algorithm, but Northern Ireland has developed an algorithm as well. So yes, we didn't take part in the national audit, despite a lot of campaigning to our Department of Health. A local charity took up the stone in the shoe. They funded the audit, which was done by the Cancer Registry in Northern Ireland, so it is a legitimate audit. It was published in JAMA Open Network in January, and as a result of that publication, we presented at the Northern Ireland Stormont government, and our health minister has now commissioned a metastatic breast cancer pathway. So that is why, I suppose, why the data is really important, because we don't have metastatic breast cancer pathways, and now as a result of the data we have one. So Mark, I have been invited with the director of the registry to present to Naomi, which I think we have a date, the 25th, the 26th. So I think in the UK it's really important that we learn from each other. Northern Ireland is very small, but we have a really, really good data set that goes back to the 1990s. So we're going to be able to look at recurrences from primary breast cancer to metastatic disease. We're going to be able to look at that by subtype, by age group, by biomarkers, all of those things. So I think it's really important that we learn from each other in this as well.
Yeah, I completely agree. And the Northern Ireland data are enviable. I think the other thing is that in England and Wales, obviously I've not talked about the national audit of primary breast cancer, but because those primary cases are captured effectively because they're new cancer diagnoses, the data completeness is much greater for primary than metastatic cancer. So it's this particular metastatic cancer problem. But yes, Northern Ireland is absolutely a beacon in that respect, and I wish we had the quality of data that you have.
Lady at the back in pink.
Hi, Mark. Thanks very much for your presentation. That was really interesting, and it's a subject that's quite close to my heart. In Scotland, we just can't get our people to budge on this at all. So we're trying to progress that as well as we can. So just a couple of questions for you. When you started out on the Naomi project, I'm going to be a little bit selfish here and ask you a couple of questions. What were your greatest challenges in terms of how you have kind of progressed and got it to the point that you have? And were there any surprises in the data that you have collected? So based on some assumptions that we'd made in terms of numbers, was there anything that came out of there that you thought, my goodness, we've been kind of operating on this assumption for some time now, and actually the numbers are way out in reality?
So the biggest challenge is identifying those patients with secondary breast cancer, for sure. And the biggest surprise is the low number of people who are receiving CDK4/6 inhibitors. We thought it would be much higher. And I mean, Carlo will be able to confirm, if you look in his practice, if you look in my practice, the numbers of ER positive, HER2 negative patients getting primary CDK4/6 inhibitors would be much higher. And what we're trying to unpick now is what's happening to those patients. Are they getting endocrine monotherapy, so just taking letrozole or tamoxifen or one of the other hormonal drugs on its own? There are some data from a somewhat notorious European study suggesting that's acceptable, but most of us don't feel it is. The other issue is that before the CDK4/6 inhibitors were launched into the market in 2017, a very large number of people would have received chemotherapy, and that number should be dropping precipitously. So one of our worries is that people who, I think that the standard of care would be a CDK4/6 inhibitor continuing to receive chemotherapy, which is no longer the first choice in the overwhelming majority of those people. So that's tantalizing data that we're trying literally at this moment to unpick. One of the other questions, I have to be awfully careful about what I say, because everything that we say in these audits, because it's part of NHS England, actually has to be approved through a very laborious process. And I'm not sure who's in the room, but our
Nobody
team
from NHS. You're amongst friends, Mark. Nobody from NHS England, but
Fine,
we are being recorded, and I'm not sure if we're being hacked.
Yeah, in the project team, the team, which is professional data scientists, and we've got a number of fellows that we employ, spend an awful lot of time writing the reports that we're expected to write, and it takes a huge amount of time. So by way of example, we will publish our second State of the Nation report probably in September, October, but we're expected to submit the first draft to NHS England this month. And everything has to be approved by multiple different people before we can put it into the public domain. So I know I've seen data that will not be able to be shared publicly for several months, and that's a function of it being part of NHS England. And the other huge question is what will happen when NHS England withers on the vine, because there's no guarantee that whatever replaces it will emphasise the importance of collection of audit data in the same way.
I mean, I think that's really important what Mark says about the CDK46, because the audit's like sunshine. It's shining light in corners of the NHS that have not had light shine them. So if we've got 4 in 10 people having only CDK46, that's low. So the question is, who's not giving the CDK46? Who's giving chemo first line, which is no longer acceptable? There are indications for it, but they are small now. So where's that happening? And this is the beauty of the audit, is trying to make sure that women and men with secondary breast cancer get the best care to international standards, not what somebody thinks that's the best thing that they think is a thing to do and are not up to date with the data. So, and that's the reason these audits are so important, is that they shine this light into bits of the NHS about what's going on. And the aim would be to use that data. And the question is, where's that happening? Why is that happening? And how do we make that number bigger and less women get chemo if you're eligible for a CDK4/6? Donna.
And there's also an issue of tracking it over time, Carlo.
Yeah.
And a piece of really good news is we've just appointed a medical oncologist to be a research fellow. So because of the way all of this has evolved, and in the previous audit, which was the National Audit of Breast Cancer in Older People, there was essentially very little focus on systemic treatment. And it was only when they started the metastatic audit that they thought it would be sensible to have a medical oncologist involved. So we're a little bit behind, and we've had various different attempts to try and recruit a fellow, and it frustrates me beyond measure that the Association of Breast Surgeons have a fellow, and we know that the Association of Breast Surgeons fellow is largely funded by a pharmaceutical company, but the Association of Breast Surgeons haven't had to declare that, whereas we tried to get a fellow funded through a collection of different pharmaceutical companies for the metastatic audit in collaboration with the UK Breast Cancer Group. And the UK Breast Cancer Group made it clear that the funding was going to come from pharma because we don't have any money otherwise. And that was deemed to be unacceptable because it may be tainted. So it's great that we've got a core funded medical oncology fellow. And believe you me, the first thing they will be doing is digging into this CDK4/6 inhibitor data, because I think of all of the questions we could ask, that is first of all the one where there seems to be great variance. And also because of the frequency of ER positive, HER2 negative disease, it's going to affect the largest number of people with a secondary breast cancer diagnosis. So that was my motivation for wanting to get involved in the first place, was to look at these variances in treatment.
Donna.
Sorry, really quickly, mine's more of a comment, really appreciative of how important data is. I think it's really sad that the people that are inputting the data are few and far between, band 2, band 3s, and as you say, all sorts of pump primes in the primary setting. I think we need to, as well as investing in the COS data systems, Somerset Cancer Registry, we need to invest in people to be actually sitting and inputting the data.
I couldn't agree with you more. I think the challenge is that the NHS can't afford to do everything, and the collection of high quality data is extremely expensive.
Sam, you got a,
Oh.
Sam's got a, oh, sorry. Perfect. Yeah, and I think the patient, I mean, Mark is a phenomenal advocate. He's, if, you know, you don't want to cross him scientifically, he knows his stuff. He's also, you know, a fierce advocate for patients, and actually having Mark at the head of the audit, while his hands may be tied in terms of NHS England process, I believe me, behind closed doors, I'm pretty sure he's very vociferous in his views, although he won't say this clearly because he's diplomatic. He's very vociferous in his views of the issues that he faces. So I think the ladies in the audience have a very strong advocate, and an advocate who does not mince his words in the medical community. A lady at the back. Yeah, one more question.
Good morning, thank you. Carla Whitbread, 13 and a half years of lived experience, and I actually sit on the Naomi panel as a patient representative. And as a patient, we should be very afraid of the state of the nation right now. And I give great credit to the Naomi team to unpick all that's been, what has been presented today, because when we first started, it was a real mess. My question to Mark is, you have your perfect target audience right here. We are women, men living with the disease, and we want to fight to improve services. What can we as patients do in our local communities to advance fast-forward improvements in data recording to improve services?
Probably it's around a local data champion. So wherever you live, wherever you're being seen, you need to try and identify a data champion, and then you need to ask them to engage with us potentially. And on my final slide, we showed the contact details. And most of all, complete those recurrence forms, because if those recurrence forms are completed, almost doesn't matter who completes them. If those get coded, that information will be fed to COSD, and COSD will feed that information into the audit. So in a sense, there are people whose job it is to fill out the forms. And Carla will tell you, if you want to start a new treatment on a patient with secondary breast cancer with one of the newer drugs, the burden of NHS England paperwork takes you about as long as it takes you to have what might be a very complicated discussion about treatment with the patient. And we're not looking for more paperwork. But if you can get those forms filled in, then we will capture that data, albeit with a time lag. And I think it's really important that people understand that we get the data that's given to us. We cannot collect data independently. And in a sense, I gave a talk in a library at the Royal College of Physicians a little while ago, and it was filled with books in a neat, orderly row. Cancer data isn't like that. What cancer data is like is somebody goes into the library and picks every third book off the shelf and chucks it into a pile in the middle. And our data scientists manage to sift through that. And I've got to say, they are some of the most impressive colleagues I've ever had because of their dedication and their ability to actually pull meaningful data out of random facts that's submitted to them.
So Mark's basically saying, if you're living in England, write to your chief executive of your hospital and ask, are you filling in Mark's form? Mark had a picture.
That's not my form. Don't put my name on it. It's a COSD form.
The Naomi form, and ask, what's the process in your hospital for completing the Naomi form and getting into the audit? So that form should be completed. So as patients, ask your local hospitals, where is that form? Who's filling it in? What's the process for collecting the data around metastatic patients? So you can champion that form, and as patients ask, what is the process of that form? So those are real things you can do. You have the power to write to your chief exec, to the local Cancer Alliance. What is the process? This is an English process, by the way. So you can make a difference. You can advocate. And to give an example, sorry, the lady whose name I haven't escaped, who sits on Naomi, your voice is powerful. and patients have to listen. All hospitals have committees looking at patient experience and have to listen to patients. So your voice is really vital here. Mark, a massive thank you.
Carla, while we've been on, very quietly in the background, I've been on Amazon. And a big sack of gravel is about to arrive in Liverpool. And I want you to give it to all the people in the audience and get them to put it in the shoes of the people that they're seeing. But I think the question to ask is, next time you see your oncologist, ask them, how is my data being fed into the national audit?
Exactly.
Is it being recorded?
Be that stone in the shoe of the organisation.
So sharp gravel on its way.
So, Mark, thank you for a fantastic talk, for taking it, and also thank you for advocating for the data, because I know it's a big job, not an easy job, so thank you for what you do for the patients and for getting the data. So big hand of applause to Mark. Thank you.
Thanks, Carlo.